I will take an intubation away from a resident. I will take an intubation away from a respiratory therapist. I will take an intubation away from a paramedic if they are not prepared for everything they're about to do and everything that could go wrong. You've got to be prepared. I like the use of checklists. I'm going to share my checklist with you. You don't necessarily have to use my checklist, but you have to use a checklist to make sure you're not forgetting anything before you intubate. I use the SOAP P, Me, E mnemonic. There's a lot of different SOAP, Me mnemonics, and I couldn't boil it down to just one. So I've combined a couple, and I have the SOAP P, Me, E mnemonic to make sure that I hit everything. First of all is suctioning. Nothing's worse than getting in there, seeing vocal cords, and all of a sudden a bunch of phlegm's in your way and you can't see it. If you just had some suction, you could pull that out of the way and get your airway. But if you're not prepared, you're gonna have to abandon the attempt. This can take the longest to set up, so I typically call for this first. If there's not a canister in the room, if there's not a suction regulator in the room, this can take some time to find and get set up. So I'm glancing, do I have suction ready? Is it working? Great. Once I have suction ready, or I've sent people to get suction set up, I'm thinking about pre-oxygenating my patient. Everyone gets pre-oxygenated. Everyone gets pre-oxygenated. Even if your sats are 100%. If you're breathing room air, your lungs are only 21% full of oxygen. If I let you breathe 100% oxygen for 5 minutes, now these big lung tanks, these big oxygen tanks in your chest are gonna be 100% full. Everyone gets pre-oxygenated. At a minimum, use a non-rebreather with the knob turned all the way. Not to 15, turn it to 15, and then keep turning it until you are at flush rate. If they're a COVID patient, you're struggling to oxygenate, if they've got significant atelectasis, you may need positive pressure to pre-oxygenate them. You can do that with a non-invasive ventilator or a bag valve mask device with a PEEP valve on it, but everyone gets pre-oxygenated. Next, you gotta assemble your airway equipment. This is the very minimum that you need to secure an airway. You've got to have a laryngoscope, you've got to have a tube, you've got to have a stylet, you've got to have a syringe to inflate that cuff, and you've got to have a bag valve device. Many of us are spoiled by respiratory therapists who set this up for us every time, and we never process it. I encourage you, if you are intubating patients, process this every time before you intubate. Go through the equipment, make sure that you can name every piece of equipment that's needed for the intubation attempt. Next is pharmacology. Typically when I say pharmacology, this is what we think about, our induction agent and our paralytic, but there's more to it than that. I'm a ketamine rocuronium guy, but there's more to it than just your induction agent and your paralytic. Every intubation can cause death. Every intubation can result in cardiac arrest, and you need to be prepared for this. If your vital signs are at all unstable, if your shock index is greater than 0.7, do a good evaluation, figure out what's going on, resuscitate them, and that may involve a vasopressor. So when you think about pharmacology, also think about, do I need to have any other medications ready? Do I need to have some norepinephrine ready? Do I need to have some push dose epinephrine ready in case this doesn't go well? Additionally, if you're using rocuronium, there's a couple of different papers. This one showed that 2.6% of the time when we intubate, the patient is left paralyzed and wide awake. This other paper showed that it can be as high as 7.4%. The independent factor in these was use of rocuronium. So I like rocuronium when I'm intubating as my paralytic, but if you're using rocuronium, realize that is gonna last a lot longer than that ketamine. So when you push that rocuronium, you need to be ready to go. So when I say pharmacology, I mean your induction agent, your paralytic, anything you need for unstable vital signs, and your ongoing analgesia and sedation to prevent ED awareness. This is what I mean when I say pharmacology. Make sure you are processing all of this. Next is positioning. When I say positioning, everybody thinks, okay, I'm gonna get them up in this sniffing position, I'm gonna move their head up, and that's correct. But I also like the head of the bed elevated. It is essential in patients like this because that big belly will push up on the diaphragm and decrease your residual volume and decrease the amount of possible apnea time before they desaturate. So if they are obese or if they are pregnant, you put the head up at 30 degrees, that brings this belly off of the diaphragm and gives you more residual volume so your patient can go longer without desaturating. And I also like Bruce Lee. Bruce Lee said, "I do not fear the man that has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times." If you're going to need to do this occasionally, if you're going to need to intubate with this head of the bed elevated on some occasions, why not do it every occasion so that you're prepared, so that you're doing the exact same thing every time and you're not making any mistakes? So make sure you have the head in that sniffing position. And then furthermore, if they're obese, you need to have the head of the bed elevated to 30 degrees. Why not just do it every time? My first M is monitor. We are spoiled by really good ER nurses who set our monitors up for us. However, you are responsible for making sure this is done. We do have new hires from time to time. Occasionally things are missed. You are responsible for making sure your monitor is set up. Specifically, when you look at your monitor, you want to look at your blood pressure. Make sure that your blood pressure is set to cycle at least every 3 minutes. On a patient that I'm worried about that might be at risk for post-intubation hypotension or post-intubation cardiac arrest, there's a non-invasive blood pressure stat button that you can push that will just cycle blood pressure after blood pressure after blood pressure for the next 5 minutes. Additionally, if I'm really worried about the patient and they can wait on the intubation, I may put an A-line in so that I have beat-to-beat blood pressure measurements during the intubation and I don't get caught by surprises. If this is set to cycle every 30 minutes and your patient starts to crash after the intubation, you're probably not going to know it until they lose pulses. You are responsible for setting this blood pressure and making sure that it's set to cycle at least every 3 minutes. And then you've got to have the pulse ox on. You got to be aware of what that O2 saturation is. If you go over to pulse ox on the monitor and select that, there's one option that says rate volume. You turn that rate volume up and it adds tones to your pulse ox. So if I'm at the head of the bed and I'm looking at the airway, I can tell by the pitch what their sat is. So I hear this dee 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 doo doo doo. I hear that pitch falling. I know my patient's desaturating without looking at the monitor and without somebody standing in the back room going, "Sat's 97, Sat's 96, Sat's 95. I hate that. I want a silent resuscitation room. I would rather have that beeping that gives me that constant feedback. You are responsible for setting up your monitor. My first E is your emergency backup equipment. I don't care what emergency backup equipment you list, but you've got to be proficient at it. Video laryngoscopy is many people's backup. In my opinion, this should almost always be your first line utilization, but if you're not using it first line, have it as your backup. A bougie is an amazing tool that has saved my tail many a times, but you have to practice with it. You have to practice with it. So honestly, if I'm using a standard geometry laryngoscope, video laryngoscope, or direct, I'm often using a bougie just so I can keep my skills up with it. An LMA or supraglottic airway is clutch. If you have any issues ventilating the patient and getting the airway, you can thunk in that LMA, and if you can ventilate through that, you have all the time in the world. There's no emergency in getting that airway. And then make sure you're prepared mentally to do a crike. If you cannot secure an airway and you cannot ventilate the patient, you've got to cut the neck. You've got to be prepared to do a crike. Anytime you are intubating, you have to be prepared to do a crike. My final E is end-tidal CO2, and this is what I mean. I don't mean that little colorimetric thing that turns from purple to yellow. You need waveform end-tidal CO2. This gives me so much more information than the little colorimetric thing. You actually have quite a bit of acid in your stomach, which can cause the colorimetric to change. All it's doing is detecting acid. And so I want that waveform to show me a good squared off tracheal waveform, confirming that I'm in the trachea and not in the esophagus. Furthermore, the end-tidal CO2, waveform end-tidal CO2, gives me a ton of information about the patient's perfusion, about the patient's lung status. So this is something that I'm getting set up before I start to intubate. This is it. This is my checklist. SOAP, P, me, E. I go through this every time before I intubate. And I expect you to go through a checklist every time before you intubate, or I may take the intubation away from you.